operative nutrition drink. You know, you look after their analgesia requirements. There's a whole list of things. There's various protocols. You just Google enhanced recovery protocols. You can actually find that you have reduced hospital stay and fewer complications. So these are some of the things in an enhanced recovery program. So I just put this there for you to go away and think about these things, because obviously an enhanced recovery program will have to suit your local environment. But when you're thinking about improving outcomes for your patients, you need to get away from just thinking, well, I need to do a great operation, or I need to give them the latest, you know, chemotherapy agents, or I need to get the best LINAC, you know, radiotherapy machine on the market. It's actually all these little things that can actually make a big difference as well. So just to round up, just a few limitations you need to be aware of. You know, with the Konofsky and ECOG status, comorbidities are more prevalent with age, but you can have elderly patients with good performance status, but they have a whole load of comorbidities, which might not become an issue until you give them some horrible cytotoxic drug because you want to cure them. Okay. So you do need to think. Yeah, it's all right. We're allowed to have a go at each other. They'll get me back, don't worry. So you do need to think about the high risk of complications that you can get with certain treatments, even if your patient appears to have a good performance status, okay? And that's why now they're looking at additional tools to assess elderly patients. So rather than just looking at whether or not they can get out of bed and put their clothes on and go to the toilet, they're looking at additional tools, what we call instrumental activities of daily living. And this is a good paper looking at a geriatric assessment in older patients. And all this is, I don't know why they came up with SCUM, but that's that seems to be a good way of it. So now you're actually looking at function. So can this patient go shopping? Can they cook and clean? Can they use the telephone? Can they manage money? So all of those aspects are now of added importance in your elderly population, because if they can't do all of these things to start off with, if you give them radical treatment, which has got, you know, significant side effects, you could actually significantly reduce their performance status. And this is just comparing it to the simpler version of activities of daily living. So finally, don't forget, this is a team sport, okay? It's not a game, but it's teamwork. You have got several members of your multidisciplinary team who have a very important role to play. And I've deliberately left out surgeons and oncologists from that list. Okay. How many of you have worked with speech therapists, dietitians? Show of hands. Okay. How many of you know what a dietitian is? Look, we have dietitians in the UK. Sometimes I do wonder what they do. But anyway, this video is not going out to the UK, so I'm okay. You know? But look, joking aside, you know, having colleagues who specialize in, you know, nutrition, who specialize in, you know, voice rehabilitation, all of those aspects, they will always take things to another level than you can. So I would suggest you go back to your various teams, and if you don't have all these members in your team, you should actually humbly suggest that you get to work closely with these guys. They're very important. And at the bottom, I've put anesthetists and intensive care consultants. Very important, because if you're going to do a big operation on an elderly patient, so I had an 80-year-old patient who had an advanced hypopharyngeal cancer. So this is a cancer, lower part of the throat going into the esophagus, needed to have a gastric pull-up. And you can imagine the words, you know, 80-year-old, laryngopharyngectomy, gastric pull-up. The two just didn't go together. Okay. So before you could touch the patient, you have to talk to your anesthetists, you have to talk to your intensive care colleagues, because that patient will spend a week in intensive care, you know, at least. So they need to be comfortable that, you know, they prepared themselves. And that's what we did, and the patient was fine. You know, he left home. He did spend a good couple of months in hospital for other reasons, but we won't go into that. But that's very important, that multidisciplinary team. So to conclude, so comorbidities are more prevalent with age, and there's lots of data, several studies which have shown that it is an independent oncological prognostic factor in terms of its effect on overall survival. So that's something you do need to take into consideration before you offer your patient radical treatment. If they have got significant comorbidities, you have to ask yourself, what would be the impact of the comorbidity on the patient's overall survival, and what will be the impact of your treatment on that patient's comorbidity? So that's the first question you need to ask yourself. If you're looking for a tool to use, the Charlson Comorbidity Index is well recognized. It's been tried and tested for many years. So if you want to use that in your daily practice, that's adequate. But you need to understand that there are other tools available. I haven't talked about, for example, the Adult Comorbidity Evaluation Score 27, which is more cancer specific. I deliberately didn't put that in because we could spend a whole day just talking about various comorbidity assessment tools. The other thing you need to remember that a good ECOG status or Konofsky score can actually mask existing comorbidities, which could influence your cancer therapy outcomes. So don't just focus on the ECOG score or the performance status alone. For elderly patients, maybe look at additional assessment tools, looks at instrumental activities of daily living. And the other thing to bear in mind is that a lot of gold standard clinical trials that are the fundamental basis for a lot of treatments we offer our patients have excluded the vast majority of the population with comorbidities. So you need to, again, take that into consideration. So, good. Any questions? Okay.
Is the performance status influenced only by the effect of the tumor on the patient, or is it influenced by some other factors also, which is not related to the cancer?
Yeah, so that's a great question. So you do always have to, when you have a patient who comes to you with symptoms, ask yourself the question whether or not their performance status at that time is the effect of the tumor or if it's the effect of pre-existing disease. So a typical example would be a patient with a laryngeal cancer, which, as you know, these tend to grow slowly. So they may have had this for 6 months, and as the tumor gradually fills up their airway, their performance status over the last 2 months may suddenly have gone down, and they present to you in the emergency department with an airway obstruction, and you might get a story from the relatives that says that 2 months ago they could only walk 10 meters before they got breathless. But in that case, if their performance status before the evolution of their symptoms was normal, then you can say to yourself, well, look, if you treat the cancer, that might actually improve their performance status. So that's a good question. You do have to unravel the two.
Thank you, sir.
Okay.
If there's a patient who has an isolated solid tumor, and then we operate on him, but on CT scan we couldn't find any evidence of metastasis anywhere. So how do we decide if we have to give adjuvant radiotherapy or chemotherapy, or we don't have to?
Okay, so that's kind of going a little bit into our MDT discussion, but I'll answer very briefly. Different tumor types have got different criteria that determines whether or not you give adjuvant treatment. And usually in the context of surgery, if you do an operation, you don't just throw the specimen in the bin. When I said about putting in the bin, I meant the pathology bin, okay? I didn't mean, the incinerator bin. So you put it in the pathologist bin, and the pathologist will then analyze it, and depending on the margins, so usually margin status, if you did a lymph node dissection, for example, and the lymph nodes were clear, and the margins were clear, and there were no other adverse pathological factors, such as maybe perineural or lymphovascular invasion, you may decide that the patient doesn't need adjuvant treatment. So what you're asking yourself before you give adjuvant treatment is, what is the risk of recurrence in the context of the pathological information that you already know for that patient, and that will determine if you give them any further treatment.
Thank you, sir.
Okay, but it varies depending on the tissue type. So different tumor types have different criteria.
So
yes, sir.
How will we manage a pregnant cancer patient? Is there any way that she can deliver the baby safely?
Okay, wow, you're really asking some. Another great question. You're asking some very sort of esoteric questions. These are the sort of questions that I ask my registrars who are doing their final year, so pre-consultant exams, because it really, I like to see as their brain is being fried while they're thinking of an answer. The answer to the question is it will depend on the tumor type. So there are some tumors that are more indolent. So a typical example would be thyroid cancer. So if I had a pregnant thyroid cancer patient, maybe 35-year-old, who was pregnant, and it was a classical differentiated papillary thyroid cancer, I would tell her to have her baby and come back after she's delivered safely to have the baby, to have treatment. But you might decide to monitor the patient closely during the pregnancy, and that will, if things change, then you might decide to intervene surgically. But I think for other tumor types, I mean, would you?
Yeah,
you don't get that problem in prostate, do you?
Not often, no. I think if it happens in prostate, we write the case report. But I think it depends on the tumour type, the tumour stage, how far through the pregnancy they are, and what treatment you're going to be giving. So it's very individualised.
Yeah. Yes, and it is multidisciplinary. That's a very good point. You know, you have to talk to your obstetricians. You know, I can give you an example. I had a lady with a tonsil cancer. She was in her 3rd trimester. At 32 weeks, we had our suspicions. We normally have to put patients to sleep to get a biopsy. She was keen to avoid a general anesthetic. It was her first baby. Keen